serous tubal intraepithelial carcinoma. So please.
So till he prepared this. Okay. So thank you again for your presence so late today and Friday. I will take your time from your family, from everyone. So I think you are now tired from me and from everyone. But you know, when we talked in this meeting, we have like big subjects, like endometrial carcinomas, like 6 chordostromal tumors. This is one of the very discrete elements. And I think the last slide of Dr. Joseph Carlson was very good introduction to me to this subject, which is diagnosing the serous tubal intraepithelial carcinoma. This is a consensus-based recommendation. And you know, let us go to the slides. Again, this is the Roswell Park Cancer Institute where I work in affiliation with the University at Buffalo, New York. We have a residency program at the University of Buffalo, New York. We have 16 residents. Those do mostly anatomic and clinical pathology. Some of them do only anatomic pathology for 3 years. Some do only clinical pathology. And at the Roswell Park Cancer Institute, across the street from the university where I am located, so we have a fellowship, 2 fellowships. One, let's go to the previous slide if you need my email address, because many people asked me about this. If you want to write this email address or take picture. So we have a general surgical pathology fellowship. We have 5 fellows. Those are doing everything, GYN, chest, lung, you name it, breast, everything. Then we have a dedicated fellowship. I directed this for breast and GYN, combined breast and GYN. Then when I came last year here, I said, okay, let us create another fellowship, which is international fellowship. This is for anyone in the world, okay, including Egypt, anywhere. Just this is for the people who wanted to come to specialized in some certain organ or two. The age should be young, so until the age of 80 only, okay? Yeah, until the age of 80 years old, not more than that, or maybe 90. Anyhow, so it is not, there is no age factor in the United States, and anyone can apply for this. If you want to be like, to expose more to breast or GYN, or combine the breast GYN, or some lymphomas, or something like that, for sure I'm trying to encourage people to do breast and GYN, because I am a breast and GYN pathologist. I am a biased, you know, I should be, I don't know. So we have started this, and we have the first candidate from University of Ain Shams. We have with us, she's just there for the last month, very good candidate. She is elected to have a breast training. We have a very good exposure there, thousands and thousands of cases. You're exposed to frozen section, molecular histopathology. We tailor this. So it is from, you can come for 1 day up to a year. Okay, it is, we don't provide any salary or anything. You fund yourself, or you find a funding source for you. Okay, if you have any more questions, just let me know, send me email or call me, and we'll give you more information. Some people are interested, but you have to know the most important triggering factor is the fund. There is no funding on this. This is free. You come to do for free. You find yourself the housing, we will help you a lot for sure, but you know, as I said, this is important. Any question in this? Very quick. No question, very good. So as I said, this is international, for the international only people, I mean, coming from outside. And this is the place here you go. This is, I'm not in this nice building, I'm in the building in the back, so, but not in the basement, thanks. Okay, so we'll talk about the serous tubal intraepithelial carcinoma. As Dr. Carlson said, this is now we have a huge fund of knowledge that the serous, the epithelium of the fallopian tube is the source of the high-grade serous carcinoma. And this is here very nice diagram. Here you see the fallopian tube. The cells lining the fallopian tube could have like what we call B53 signature. We will describe all those, or dormant stick then becomes staying like that or becomes active and active stick, which is the source of the disease, then becomes high-grade serous carcinoma, as shown here nicely in this diagram on this slide. But when this term has been introduced, you know, it is introduced maybe in the beginning of this century, 2000, 2001, and this paper here, maybe one of the first papers in this, called occult carcinoma in prophylactic oophorectomy specimens. And the prevalence, and they study here those cases from the fallopian tube submitted for some in the BRCA patients, mutated patients, prophylactic. And in this particular paper, they did found one only case. And this is the picture from black and white. If you look to the right, this is the benign fallopian tube epithelium. And to the left, there is this growth, abrupt growth. You know, the right side, there is the fallopian tube. Then to the left, this cribriforming growth of this. Even black and white picture, but still, you can, even sometimes better than the colored one. So this is the first introduction of this. Then we have another group at Europe, and they published this maybe in the same year, dysplastic changes in prophylactically removed fallopian tubes of women predisposed to developing ovarian carcinoma. And in this particular paper, they did immunohistochemistry back then in the 2000 or 2001. They used, as you see these pictures, the cyclin, they used, this is the histology in A, then in B, the Ki67, and this is the stains used back then. I don't know what stains they did or what colon. Then cyclin G1 and the B53, in addition to multiple stains to the left here, they introduced the subject here. And this was like the sparking event or the sparking publications. Then after that, groups from different institutes started to dig this more down, as we will go. But the first question, why should we accurately diagnose a stick? I can just have all this presentation one slide only. I can just give you the stick is the in situ high-grade serous carcinoma. All the features of high-grade serous carcinoma, but in situ in the fallopian tube, and then I go. But I have to, if I do that, Dr. Manal is sitting there, and everyone will say, what did he, this one slide for us, and they just left. So I have to give you something, okay? So bear in mind with me here, and why we diagnose this? To predict the increased incidence or risk of high-grade serous carcinoma. As we said, this is now most of the cases are arising from this. So we have to dig for this, and we have to diagnose it right. Because if you have patient prophylactically, or not prophylactically, just to remove the uterus for leiomyoma, or for she don't want the uterus for any reason or the other, then we submit the fallopian tube and we find the stick only. What we are going to tell her, what we are going to write, how we handle this. So this is for, we will tell you, you may have predicted increased incidence of high-grade serous carcinoma, and we may go back again to remove the ovaries, or we will see. And also to support a lot of research in the development of strategies to prevent or at least early detect the high-grade serous carcinoma. And I'm included in this study, big funded study at the United States with a lot of institutions, and I am one of the pathologists in this study, just to characterize, not that to characterize the morphology of the fallopian tube, to go what next, what we do, how can we early detect this, by serum testing, by whatever we do. So this work is in progress. We do proteomics, we do immunomic, we do a lot of things, sophisticated studies to reach some reasonable strategy to early diagnose this. So to start with, we have to diagnose this first. Even when we study this, we send all those cases to proteomics and immunomic. We send the right specimen for this. And there is a lot of inconsistency among us in diagnosing stick, as we will see. But how consistent and reproducible we are in diagnosing a stick lesion? We are very reproducible in diagnosing high-grade serous carcinoma. If I show high-grade serous carcinoma to 100 pathologists, maybe 99 of them will say high-grade serous carcinoma. The stick is different. Look at this study. Serous tubal intraepithelial carcinoma, diagnostic reproducibility and its implications. This is quote-unquote 6 experienced GYN pathologists, and they saw what's supposed to be stick. If you can see here to the left, only 3 pathologists only agree on a stick, 3. Then, and so on the other 16 cases. And when we do the study, the consistency among people, the statisticians do what they call kappa factor. If they agree, everyone agree, they take kappa of 1. If nobody agrees, just random chance, we have different 0.9, 0.7, and so. And the kappa factor here is 0.45, which is fair to good reproducibility. And you see the curve here, how many the cases is scattered among the pathologists. One of the cases here, just one pathologist in the red bar, just to say it is a stick, and so on. So then myself, and in collaboration with other 4 GYN pathologists, we did this. We said, okay, guys, send us everyone has a stick, send the stick, review it, and send it for the 4 of us from 5 different institutions. So every institution sent the cases, and so on, centralized the cases, and we reviewed the cases, and if 4 of us agreed, we call it stick. If 3 of us agreed, still we call this stick, 75%. But if only 2, like this case here, so we call it suspicious for a stick, and to the right, lower here, only 1 send it, we call it not stick. And those are the cases, and those are the institutions: the Roswell Park Cancer Institution, the University of Pittsburgh Medical Center, the Mayo Clinic, and the MD Anderson. And all of us has a GYN expertise. And this is the numbers here of the cases. The institution, 5 institutions, but 4 pathologists. And the stick confirmed, look at the numbers here. Anyhow, the percentage of agreement among us, the 4 of us, is 82% till 43%. Among stick cases diagnosed as a stick at our institutions then we said, okay, we need to do this. We need to do this. We have to do this. And tons of publications studying the reproducibility. But there is there is criteria. And when you go to the criteria, I will go with you through the criteria. It is the criteria of what? It is the criteria of high-grade serous carcinoma. But we need to apply it here. Sometimes this is something tricky here. But let us go to the basic of the anatomy of the fallopian tube. The fallopian tube lined with types of epithelium: the ciliated epithelium, the secretory, non-ciliated, and the intercalated cells. Let us concentrate on the ciliated and the non-ciliated secretory cells. And every one of them has function, and this is not the function of this lecture. I'm not going to go through those first because I don't know, I forgot them now. And the second, I have no time to do this. So this is here, the lining here. You see most of the cells has cilia. And as the patient becomes older, the cilia goes away. The secretory cells numbers becomes increased, and the ciliated numbers becomes low in number, because the cilia is used to deal with the ovum and the fertilization and all this stuff. Then this is the model here of the precursor lesions of the high-grade serous carcinoma. Let us go to, we have stick, which is serous tubal intraepithelial carcinoma, the B53 signature, and the scout. And you will see this. Scout didn't find its way to the literature. I will show you the paper. And in scout, there is low expression or loss of the BAX2, but stick and the B53 signature, you have TB53 gene mutation. And the gene called the TB53. The protein is P53, okay, when we do immunohistochemistry. Let's go to the scout, which is secretory cell outgrowth, BAX2 and the serous carcinogenesis in the fallopian tube. And this is published by the people, different institutions, and Dr. Crum here from the Brigham and the Women Hospital. And from this study, they said there is, they introduced this terminology. And as I said, it didn't find its way to the literature. Do you use it, Mesa? Scout? No, we don't. It is, sometimes you do some work and nobody interested in this. And sometimes other work will show its way. So it is, they called the scouts, or the secretory cell outgrowth, discrete expansion of at least 30 secretory cells with no cilia. And they are positive for BCL2. And BCL2 is the secretory cell marker in the normal fallopian tube. And they are negative for B73, and the B73 is a marker of the ciliated cells. This is normally in the normal situation. And they did find in those cells, in the scouts, they lose the BAX2 staining, and there may be some abnormalities in the BAX2 gene. And B53 either altered or wild type. Then we have a case here, and I have this case maybe like a month ago myself, and I did find the fallopian tube is almost replaced with this mucin. This is something aside, not stick. just mucin replacement of the fallopian. Most of the epithelium, as you see at the top left here, is just replaced with this. This is close-up view to show you the fallopian tube epithelium is just replaced with this mucinous epithelium, maybe some mild atypia in the base, in the basal nuclei, maybe no atypia. But I did find in this particular case in the fallopian tube as well as in the ovary an invasive mucinous carcinoma. And I'm going to find some cases, called some of my colleagues to find if you have cases like that. Did you have any cases like that, Maisa? Like mucinous lining like that? No, so I called the colleagues, maybe the first case. Then I said, okay, let us do this. And I will do the KRAS mutation in this case. And this may be called the source of the mucinous tumors of the adnexa. Because you see here, the lining of the fallopian tube epithelium, then invasive carcinoma, as you see the arrow here, in the fallopian tube, then the ovary is the mucinous tumor. So could be there is some at least fraction of mucinous carcinomas of the ovary arising from, I wanted to call this meiotic or something like that. So you will find this publication, if it is accepted somewhere, to introduce this fraction of mucinous carcinoma. Interestingly, when I did the stains on this, it is strongly positive for CK7, maybe like weakly positive or even negative for CK20 in the middle, and B53 is wild type. So this is just a side finding I did find, because the fallopian tube, we have in situ endometrioid, we have in situ stick, but this may be the in situ mucinous, as I said. Let us go back to our subject here, which is the steps to diagnose a stick, or steps to diagnose anything. So the first you do what? You do gross examination and the processing is the macroscopy. Before I should write before this the pre-analytic. You should be sure the patient name is right, the specimen is right, and you don't just rush to the slides as many people do. Just see, is this the right patient or no? Is this the right context or no? Sometimes I found patients give me endometrium very atrophic and they're telling me 20 years old. I tell them, no, guys, let us see. This is not the right. Then I looked, I found a different patient or different slides. Sometimes the slides mix it up, you know. Anyhow, this is the pre-analytic checkup. But after that, you do the gross examination and the processing. You do the examination of the H&E stain the slides or any slides you want to use the microscopy. Then ancillary studies, mostly immunohistochemistry, and then you interpret this. If you do the best and you don't have the report for this, this means nothing. So you have to report this the right way. So most sticks are localized to the fimbriated end of the fallopian tube. This is the fact number one. Most sticks are in the fimbria. If you didn't find in the fimbria, the possibility to find in the rest of the fallopian tube is lower and lower. And this is Dr. Carlson discussed this, the CFM, or the sectioning, and extensively examining the fimbriated end of the fallopian tube. You go to the fallopian tube, the line, and do cross sections, transverse sections. But when you come to the fimbria, do longitudinal sections, like here. You see longitudinal sections in the fallopian tube and the transverse sections in the rest of the fallopian tube. 2 millimeter distance, and you submit everything, all the fallopian tube, or at least the fimbria, So the diagnosis of serous tubal intraepithelial carcinoma, there is seminal paper of this published mainly by the Hopkins groups in collaboration with others in 2011. And in this paper, they outlined the required criteria for the diagnosing stick. And they put the diagnostic criteria here. I call them myself the 7 criteria. Nuclear enlargement, in 2x nuclear area compared to the non-ciliated cells, the normal cells. Marked pleomorphism, abnormal chromatin, means hyperchromagia or vesicular nuclei. High mitotic rate, greater than or equal to 2 mitosis. Figures, they didn't mention their high power field, just you find 1 mite or more, they called it high mitotic rate. And epithelial stratifications, means greater than or equal, greater than 2 cell layers, and nuclear molding and apoptotic bodies. I just copied and pasted from the paper. So those are the features, and very good features. You have to stick to those to know the diagnosis of a stick, okay? Then in the same paper, they put the immunohistochemistry stains, they use the P53 positive, and they define the positivity is diffuse intense positivity in greater than 75% of the cells, or completely null phenotype, completely negative. And in that paper also they used the Ki67 and they said should be high. And what is high, they said that the cutoff of 10%. Everyone is okay here? Because we're going to the fun now, okay? This is introduction. And in that paper, they classify stick or still or B53 signature or normal fallopian tube. And the red is the stick, and the green is the still, which is serous tubal intraepithelial carcinoma. Some people called it dysplasia. Some others called it tubal intraepithelial lesion in transition. Some people called it dormant stick. Call it whatever you like. I give you all the names here. But at least you know this is not a stick. This is something sub-stick, less than a stick, which is the still. And you can see the red is only 2. So you go to the morphology according to this paper. You go to the morphology. You say, okay, I swear, whatever you do, guys, and you come stand here and you fight. This is a stick, nothing else. Then by chance, or so it is a stick. For any reason you did the P53 and the Ki67, then you find unexpected finding, not mutant type B53. Ki67 low, so what are you going to call this? You call this still. But if it is, agree with you, P53 mutant, Ki67 high, you swear it is a stick, so it is a stick. Then go to the other, if you did this is a stick, definitely stick with the criteria, and P53 is wild type. And the Ki67 is low. So there is no immunohistochemistry at all to help you. Are you going to call it normal? No. So still you call it still. Serous tubal intraepithelial lesion. Okay? Then if it is suspicious, you don't know, what is this? Let us see this case tomorrow, after tomorrow. Then you did the stains help you. It is stick, not helping you. It is still or normal if everything is negative, and so on. And this is the picture they presented. The upper panel, top normal fallopian tube epithelium, and the lower one is the stick with the features I'm going to describe. The B53, as you can see here, very high positive mutant type, Ki67 definitely greater than 10%, and this is their picture. So let us go through those features, and I will modify them a little bit. I will tweak them a little bit to just give you something. So the morphology of the stick depend on the architecture and the cytology. When you look at the architecture, the most important here, you have abrupt transition from the normal epithelium to the abnormal. It is not like gradual, no, it is abrupt, okay, abrupt. You remember the cervix, the normal cervix, there is abrupt endocervix and ectocervix. One cell then becomes 20, okay, this is one of those. Abrupt transition between the normal epithelium and the abnormal. Epithelial stratification, we'll talk about this, cribriform formation, papillary and micropapillary growth pattern, and we'll talk about the cytology, the nuclear enlargement, high nuclear cytoplasmic ratio, the marked pleomorphism, the hyperchromasia, and the high mitotic count. Okay? So the abrupt transition, I repeat this, abrupt transition from the normal epithelium. This is like specific to this. Look at this. Okay, here, this benign here, and this is something blue. How can we do this? Do you have a mouse for me? Can you give me a mouse? Like regular mouse? Okay, so to the right, there is this normal, then the abnormal, the blue cells, this abrupt transition from the norm. This is a feature. Again, here you see the benign, then the abrupt transition of the abnormal or the blue. And this is one of the cases, 4 of us agree this is a stick. The second is the epithelial stratification. And I want to read this quote. I quoted from a recent publication in 2022 by people from Johns Hopkins here. They said, the contour of a stick is typically flat, but some degree of epithelial stratification may be present. I don't know what they mean by this. Okay, but then I reviewed my cases again. I went to the 99 cases we agreed on, and I found some cases like that. So most probably there is flat lining. Flat does not mean it is one layer. Flat means there is no much cribriforming. There is still stratification here, like flat epithelial atypia of the breast. You remember? It is not one layer of cells. Could be 2, 3, 4, could be even the whole duct is full. So this is flat. Called flat means there is no cribriforming. There is no architectural distortion. Then I reviewed another case here to the most left here. So this is like again the flat lining of this bizarre high-grade nuclear features of the stick, and even to the most right we have invasive serous carcinoma here. So if I showed you the invasive carcinoma to the right, to all pathology, you say yes, high-grade serous carcinoma. But if I showed the one to the left here, some people call it stick, some people may call it not. Then the cribriforming again, we see cribriforming. I have the cases, and I reviewed all the cases. We have a good proportion of cases have cribriforming. But the cribriforming features here is not like the cribriform of the breast, the cookie cutter. And when I studied, I said, what is cookie cutter? I don't know. Then they told me when they cut the cookies, you remember this? When you do ka'k al-Eid, this is, then I said cookie cutter means rounded, well-formed. Okay, so this is not that cookie cutters, but it is like slit-like, if you will, but we still have the stick here, and we have the invasive carcinoma to the right also. How about the papillary and the micropapillary features? Because you remember the serous carcinoma in the old days, the high-grade serous carcinoma, they call it what? They call it high-grade papillary serous cystadenocarcinoma. Then they drop the papillary. Serous cystadenocarcinoma. Then they drop the cyst. Then they call serous adenocarcinoma. Then they drop the adeno. Then they call it serous carcinoma. I wish they will stay at that level and they will not delete the serous. Yes, very good. Thanks so much. Okay, so now comes the serous carcinoma. Okay, simple as this. Okay, so this is the, let's see the papillary and the micropapillary. And you know the difference between papillary and the micropapillary. Micropapillary has no fibrovascular cores. Papillary has fibrovascular cores. That is just, I told you in the beginning, pathologists are just complex. Try to, what is this micro and papillary? Okay, but anyhow, we do that. So we have here micropapillary and papillary in this. You see some fibrovascular cores here. So this is papillary formation. And you have some maybe little here, some here and there. So this is micropapillary formation in the stick. So all those architectural features of the stick lesions. More close-up view to show you the papillary proliferation here with fibrovascular core, but the cells has the cytology as I'm going to describe. Then the exfoliation. Sometimes the cells just fall in the lumen, like those cells falling here. This is one of the features also of stick. So the features we mentioned so far, what? The abrupt transition, the stratification, all those architectural, the stratification, papillary formation, micropapillary formation, exfoliation could be artifact, and something else I forgot. Let us look at the cytology. So let us take this quote. The epithelium appears darker than the adjacent normal epithelium at low power magnification. This is low power. Start with low power, guys. I see some people go to the rush to the high power. Don't do that. Low power, you diagnose 90% of your cases with low power. Then the 10% you keep it for to use just the lens instead of going bad. Okay, again here you see at the low power, very low power here, you see dark blue cells lining this and the normal abrupt transition here. Normal abrupt transition. And the second feature, no cilia. The nuclei are often rounded. In the original paper, they say molded, but when we see a lot of cases, usually rounded nuclear features and no cilia. Okay. The next stick can occur as a single focus or be multifocal. Because of that, we say submit the entire fallopian tube. Do 2 millimeter and submit everything. And I will tell you something. When you do that, you know how much tissue you will examine? When you submit every 2 millimeter and you submit sections and all blocks, how much? Maybe 1% of the tissue. Because you cut section, one section 4 micrometer, and that's it. everything rest is in the block. Okay, so don't make this 1% half. Don't make this less than that. So submit the entire fallopian tube in every case, or at least the fimbria of the fallopian tube. You will find the sticks. I will promise, even with no PRCA mutation or anything. You see this one focus here of cells. Sometimes this is the only focus we find here. Okay, if you cut deeper, you may find more and more. Let us move to the immunohistochemistry. Immunohistochemistry, we talked about the B53, Ki67, but the people used many other markers. We'll talk about the laminin, stathmin-1, P16, cyclin E, and HMGA2. Okay, those new markers introduced in this field. Okay, and we see we use them or we don't use them. Then I will let you know what did we do. So this is the B53. We describe this. To the left, you have the strong mutant type expression in greater than 75% of the cells. To the right, the null phenotype. Both you write. I write this, for example, I write B53, column mark, positive, parenthesis, mutant type. Then they know this is not the positive wild type. The other one, I write totally negative or completely negative, parenthesis, null phenotype, or null, comma, mutant type. You do your best to avoid the clinician to call you. Not because you hate the clinician or anything, it's just because you wanted to live your life also, you have your own. So, but they will call you also, whatever you do. So this is something else. Then you have to we have the talk yesterday about the cytoplasm, or today the cytoplasmic pattern of B53. I didn't see this before in the stick, and I don't think anyone else saw this. You could be the first one. If you have few cases of stick and you did the B53 and you have the cytoplasmic pattern, I promise this will be published in a second. Like this in that paper, you see this is not stick case, this is another case. You have greater than 50% staining of the cytoplasm, and most probably you will find also high nuclear stain. Then you go in that paper, you do the nuclear staining, and you see, I'm not going through this, but anyhow, if it is cytoplasmic abnormal in greater than 50%, it is atypical. Stronger expression positive, it is atypical. Null phenotype, it is atypical also for the B53. Then the Ki67, you have to have high Ki67. That paper called it 10%, some people call it 20%, some people call it whatever, but should be high. Shouldn't be 1% or 2%. If you have this 1% or 2% after you did everything, don't call it stick, please. Call it still, serous tubal intraepithelial lesion. And you see here the Ki67 in this publication, and this is in the stick, and the high-grade serous carcinoma compared to the benign fallopian tube epithelium, complete difference. Complete difference. The stick is comparable to the high-grade serous carcinoma. So the diagnostic and the biological implication, this is the next stain, the laminin expression. The diagnostic and the biological implication of laminin expression in serous tubal intraepithelial carcinoma. In that publication since 2012, they did the B53, as you see here, very strongly positive. And they did the Ki67 very high, and they did the laminin, very nice laminin gamma 1. There is multiple, this is an extracellular mucin protein, and you see the benign and the abrupt transition here, very nice cytoplasmic expression of laminin gamma, but again, didn't find its way to the diagnostic labs. In that conclusion from that paper, they said laminin gamma 1 intensity is higher in the stick compared to the fallopian tube normal epithelium in all cases they studied. And in normal fallopian tube, laminin gamma 1 was localized in the basement membrane in the normal as we saw, but in the stick they have a good cytoplasmic expression. Then the next is the stathmin 1 and the P16. We use the P16 all the time in the high-grade serous carcinoma. How about the stick? Let us see the results from this paper here. So you have the stick and the stains here, H and E, and B53, we know this, some null phenotype, some high expression. Then the stathmin 1, here, where is the stathmin 1? Maybe one of those. Okay, oh, the stathmin is this one here, yeah. Here it is. There is some staining here of stathmin here in this here, high grade expression of stathmin 1 and B16 expression, high expression. Let us see their conclusion. They said in the stick cases, the stathmin 1 expressed in 85% of the stick cases with positive mutant type B53, and in the null phenotype in 82%. So it is good. It is not that bad, with significant difference from the normal epithelium. And for the B16, it is in 85% in mutant positive type B53 and in 63% of null phenotype. So from that paper, they said significant fraction of stick lesions can be negative for B53. We know this, the null phenotype they mean. And the stathmin 1 and B16 are sensitive and specific markers for the stick. And the addition of stathmin 1 and B16 to the Ki67 and the B53 stains improves the diagnostic accuracy of stick. The next marker I will talk about here, they use the 3 markers. I'm going to use about 1 marker only from this paper, which is the cyclin E. And this is the cyclin E here. This mouse is not just, yes. Cyclin E here in the stick, high expression of this one here in this, and those are the other 2 stains. I'm not going to talk about them. So in this paper, they said the cyclin E nuclear staining was seen in 77% of stick, while the normal appearing tubal epithelium is dead negative. Good, again, can help in this, cyclin E. And the HMGA2, potential biomarker complement to the B53 detection. And here is the stain in that paper. And this is the, what is the name of this marker? HMGA2. Okay, strongly positive in the stick compared to the normal fallopian tube. And this is the paper here. They said how many of those B53 positive, HMGA2 positive, and so on. But let us see the work we did. So we did the consensus. Then we said, okay, let us see Delphi study. Anyone know what is Delphi protocol means? Delphi. Because I don't know, then I said, let us look it up. Okay, I included in this study for a long time, but I don't know the Delphi study. This is like a mechanism when you have no rigorous criteria. Then they said, okay, we don't have rigorous criteria. Let us collect 20 experts in anything. Okay, and we see what they think. What they think. And they reach a consensus and they say this is the consensus of that particular thing. This is the Delphi study. Okay, they have expertise in the field. They bring all of them and say, what do you think this is? And the more they say, the more it is right, or they establish the diagnosis based on this. So this is just a side, because I just looked this up when I'm coming on the aeroplane 2 days ago. So the methods of this study, what we did first, step 1, we did composition of expert panel for this to do the Delphi study. And then the Delphi round 1, we showed baseline characteristics and open-ended questionnaire. We asked the panel questionnaire, open-ended questionnaire. What do you think? Can we include B53? Can we not include? I will show you the questions. Then everyone say yes, no, oh, agree, not agree, and so on. Then we collected the consensus among the people. Okay. Then step 3, we collected this. Answers, rate level of agreement between all those people, and we sent it to 64 GYN pathologists. At the end, we ended up with those expert panel, and Dr. Carlson is here, and myself, and other people from the United States, Europe, Australia, Ireland, Germany. So we have 34 GYN pathologists. Okay, and I told them, come here to ask you questions to see, we need to settle this. I think by the end of this lecture, I will confuse you more, I know, and that. And this is the features here of the people here from all over the world, and how they characterize themselves, GYN, and how many years in practice, and all this. Then we didn't implement this yet, or we may implement, but not in this study. Then we will upload the pictures to the virtual slides, and we send the people this, and we include the Ki67 and the B53 if it is present or not available, and we say, what do you think? And we give them the options to the left here. Is this a stick? Suspicious for a stick? Normal? Then everyone go to just write and look at the pictures, and not pictures, this virtual slide. You can move the slide right and left to see, and you write this, and then we collect the agreements again. And whatever Agreements, highest agreements, this will be the stick. Maybe wrong, maybe right, we don't know. But this is at least 34 pathologists and collected and saw those and write their opinion. Then the consensus, this is the consensus. I'm giving you the what most of the 34 agreed on, okay? So agreement, each fallopian tube, regardless of the indication of for salpingectomy, has to have the fimbriated end fully embedded. We have to do this, every fallopian tube. We agreed on examination of the fallopian tube has to start at the lower bowel, at 4 or 5 at maximum. We disagree that the risk-reducing specimen has to be examined on more than one level. Okay, but some people say 2 slides like the cervix. No, so we disagree on this. You can still do it. Then on the microscopy, what did we agreed on? We did agree on stick has an abrupt transition from the background normal epithelium. Next, without cytological atypia, a diagnosis of stick can't be made, whatever stains you get. Cytological changes in stick are identical to the high-grade serous carcinomas. We agreed on this. Without the following morphological criteria, a definitive stick can't be rendered. Without the following. Without high nuclear to cytoplasmic ratio, you can't call it. Nuclear pleomorphism, without this. Without nuclear hyperchromasia. Without nuclear enlargement, you can't diagnose stick without those features. And we disagree on without the following morphological criteria, diagnosis can't be done on the crib reforming. So we say no, crib reforming, that's okay. Let us see the immunohistochemistry, what we agreed on, the consensus. P53 staining only has to be performed in cases of a stick is considered based on the morphology. You just go, because some labs say, okay, let us do P53 on all fallopian tube. No. Ki67 staining only has to be performed in cases a stick is considered based on the morphology. If you consider it on the morphology, then do. Not just to save one day, okay? And aberrant P53 staining is mandatory to diagnosis of a stick. If I disagree with one of the items, I'm not going to tell you my opinion. I'm telling you the opinion of the consensus. They said that we think it is stick. And okay, then we did the B53 based on the morphology, and the B53 staining should be, if we did it, should be aberrant type, either null phenotype or cytoplasmic or strongly positive. Disagree on other things, and we disagree to apply P16, we disagree to put cyclin E, and we disagree to put stathmin 1. Okay, so the agreement to go morphology good, very nice, stick, you think, do B53. If B53 is mutant, you are good. Then in the interpretation, we didn't agree on anything. Okay, so this is the disagreement. Stick can't be diagnosed in a patient who has received the chemotherapy. We disagree on this. No consensus. Stick with exfoliation is sufficient to diagnose high grade. Sometimes exfoliation, is it high grade or no? No. So exfoliation itself will not make it high grade. You have to have invasion in the stroma. When reporting stick, it has to be reported whether it concerns exophytic growth or a flat stick. The flat I showed you, we disagree on this, on reporting this. In case of aberrant fallopian tube epithelium but insufficient arguments for the definitive stick based on the blah, 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 suggestive of stick, we disagree. We disagree to use this terminology at all. Organizational, we agreed an isolated stick indicates for genetic testing. If you have isolated, we agree. We should send this patient for genetic counseling. You can't send the patient just to go to do the BRCA mutation. No, don't do that. Any genetic mutation, please send the patient to the genetic counseling, because this has consequences on the family and the kids and the relatives and everyone. The genetic counselor has the expertise and how to convey this and how to discuss this and how to ask the patient to proceed in this. This agreement, the slides of at-risk reducing specimen have to be examined twice. We disagree on this. And isolated sticks indicate chemotherapy. We disagree on this. So we don't know what is the answer. Okay. And this is the chart here, as we said. So we have to go to the morphology, and I showed you every disagreement and agreement in this. And I think this may be my last slide. Thank you very much for your attention. And this is again Buffalo here with the snow, and the buffalo itself here. Thanks so much.
Thanks, Professor Dr. Mohamed. And now let's have about 5 minutes for floor discussion.